just get this undone.
Thank you, Dr. Nemeth. That was fantastic. Okay, so 2 lectures in, or 1 lecture in, and we've already got a schedule change. So what was going to be a talk on newborn deformities by Dr. Chan, we're going to move Miss Amanda up to give a lecture on intoeing. So the 8:35 lecture is going to be given at this time. Like Dr. Nemeth, acknowledged, we're not quite set up for question answer right in the middle or during the lectures, but after a block of lectures, we will have the speakers sitting up here. And so if you have questions, write them down, please ask. That's why you're here. All right, Miss Amanda.
So while he's doing that, I'll just start that. I'm Amanda Taylor. I'm one of the physician assistants in our practice, and we're slowly increasing the middle levels in our practice. But I started with the group almost 10 years ago, and my lecture today is going to be on intoeing. And so we'll wait till he switches it. So what is intoeing? Intoeing is one of the most common things that we see in our practice. It's a very common chief complaint. We see this several times a week. And what exactly is it? It's when the feet are turning inward when they walk. And parents also come in and say that either their grandparents have noticed that they're pigeon-toed, or they feel that their child is pigeon-toed. So I put on here the physiological causes for intoeing are femoral anteversion, internal tibial torsion, and metatarsus adductus. These are, again, the 3 physiological causes, which we'll kind of focus on this talk on, although you have to be aware of the pathological causes for intoeing as well. So when you first start seeing somebody with intoeing, I usually have them walk down the hallway. And what you're evaluating for is the foot progression angle. And what this is it's measuring the angle of the foot in relative to the line of progression during gait. And so this red line here is the line of progression during gait, and you want to measure this angle of the foot. And normal is between 5 degrees of internal rotation and to 20 degrees of external rotation. So here's a video. So you can see that her foot angle in comparison to the line of progression during her gait is internally rotated. And just a little history on her, she has rickets, which is not a physiological cause, but a pathological cause. So you also want to look at hip rotation, and the ones that you want to focus on when you're evaluating intoeing is the internal rotation of the hip and the external rotation of the hip. This is the internal rotation, and which is the main focus for femoral anteversion, and it's anything really greater than 70 degrees is excessive. And this right here is external rotation. Excuse me. You also want to look at the thigh-foot angle, and what this is the angle formed by a line bisecting the foot relative to the line bisecting the thigh. And you can kind of see here the straight line is the line bisecting the thigh, and then the angle of the foot. And abnormal is greater than 15 degrees of internal rotation. So here's some other pictures. Again, this is when their foot is kind of straight here, but hers are internally rotated. So this is, again, a picture of the thigh-foot angle. You also want to measure the bimalleolar axis, which is the angle formed by the line between the medial and the lateral malleolus relative to the line perpendicular to the long axis of the thigh. And here's pictures. You can see that here we're pointing to the medial malleolus, the lateral malleolus, and then there's the line. You want to measure it to the line that's perpendicular to the long axis of the thigh. So those are basically the main angles that you're looking for in regards to intoeing, but you also want to, again, look at the foot. Is it deformed? The range of motion, is it supple? Is it rigid? You're also going to, again, of course, look for your neurovascular exam. So we get into the causes. The first one we're going to talk about is the femoral anteversion. And what is this exactly? It's the inward twisting of the femur causing the knees and the feet to turn inward. And that's a key, and we'll kind of go into that a little bit further, is that both when you watch them walk, the knee and the patella and the foot will actually turn inward. A lot of parents come in and they feel like the intoeing is a direct relation to the foot itself, but again, it's the whole leg that is internally rotating with femoral anteversion. This usually presents around age 2 to 4, is most obvious around age 5 to 6, and usually resolves by age 8 to 10. So when you really think about it, that could be present from age 2 to 10, which is a very worrisome for the parents, and you sometimes see them very frequently in the office over those 8 years. And again, when you think about the internal rotation of the hip, it's typically around 40 degrees at birth, and it decreases to about 10 to 15 degrees by skeletal maturity. And normally the internal rotation of the hip is symmetric, but not always. It can just be, it can be asymmetric as well. It occurs both in boys and girls, but you do see it more commonly in girls. And it's the most common cause that we see for intoeing in anybody that's over age 3. So this picture right here is kind of the internal rotation. Again, normal is up to 70. Anything above that is usually excessive. And then this picture right here is about the W sitting. You may hear somebody say, well, yeah, my kid loves to sit in the W position. And if they have femoral anteversion, it's just very comfortable for them to sit that way because they have so much excessive internal rotation. And a lot of times, too, you walk into the exam room and there's the kids playing on the floor and they're sitting in that position. And it's just uncomfortable sometimes for them to sit in the crisscross applesauce position. So here comes back to where I was saying, again, when they watch them walk, here's, you'll notice that the patella will turn inward too. Again, it's the whole foot, it's the whole leg. So the patella, the foot, the whole leg is turning inward when they walk. So for treatment for this, it usually resolves on its own by age 8 to 10. Bracing does not help, and you'll get parents in here that say, well, I was put in braces when I was growing up. And that is true. They used to put braces on all people that intoed. But they've done studies, and it does not help the natural improvement of femoral anteversion. If it does persist past skeletal maturity, is usually when we start to consider possibly surgery if warranted. And again, that's a referral to one of our surgeons. And if they do surgery to treat this, it's a femoral derotational osteotomy. Next is internal tibia torsion. And this is the inward twisting of the tibia causing the feet to turn inward. This usually appears worst around age 2, and we typically see it again earlier, and resolves by age 4. And a lot of times parents will bring the kid in for being bow-legged as well. So here, if you look at this patient, you can see it's hard on this screen, but her patella are facing forward on both pictures, and it's the tibia that is turning inward on both views. So treatment for this, if it's, again, truly physiological, it usually resolves on its own. Again, bracing does not change the natural history or improvement of this. And then surgery is rarely indicated for, again, physiological causes for this. And if so, it's a derotational tibial osteotomy. Now, again, I focus on the physiological causes because Blount's disease, rickets, can also cause them. That, again, typically increases the need for surgery. The other one is club feet. That it is kind of known that if somebody has tibia torsion with club feet, a lot of times it will not resolve on its own, and then sometimes you will need to do a derotational osteotomy on those kids. So when does further workup or follow-up needed? If the tibia torsion is associated with pain, a leg length discrepancy, any x-rays findings that are Blount's disease, rickets, or any progressive deformity if the tibia torsion is getting worse. So the next one is metatarsus adductus, and this is the adduction of the forefoot with normal alignment of the hind foot. The foot is typically, the lateral border, which is this right here, is curved. They have a medial crease, which is kind of right here you can see. It kind of looks like a kidney bean, all right? A lot of times kids will come in with a chief complaint of clubfoot, so it's imperative that you know the difference between just metatarsus adductus and a clubfoot. And I know Dr. Chan's lecture, which was supposed to be before mine, was going to go into this, but we'll kind of briefly discuss it. And the one that you want to look at is the acronym CAVE, okay? A clubfoot is just not metatarsus, which is the adductus, which is the A, but they'll also have kind of the midfoot cavus. The hindfoot is inverse, where again with metatarsus adductus, the hindfoot is normal. And they'll also have equinus here. So here are some pictures. This child right here has just metatarsus adductus, and this patient has clubfoot. Although this patient, again, this particular patient has metatarsus adductus, but if you actually evaluate the patient, it could also be clubfoot, a mild clubfoot. But what you want to see is you want to make sure that this one is very supple in metatarsus adductus. And if you really look at the hindfoot, which you can't really see here, it's again normal for metatarsus adductus. Here's another picture, and this is kind of a big concern for a lot of patients that come in with metatarsus adductus, is that big toe. You can see how it kind of turns inward, where this one's straight. And that big toe is very hard to kind of make look normal like the other side, and parents really do not like that. But that's, again, a sign of metatarsus adductus. So treatment for this is, again, varies per provider, varies over the range of everything. I've even changed the way I treat metatarsus adductus over the years. I used to do a lot more bracing. But in general, if the foot is flexible and the child can really move the foot every way, there's really no treatment that's needed. If it's flexible and we can passively, or ourselves can bring it to a neutral position, a lot of times I'll have the family start, and this is more like newborns, is just some serial stretching at home, kind of stretching that middle aspect of the foot to see if there's any improvement with that. If the foot's rigid and cannot passively be corrected, that's when we kind of initiate some treatment. And again, I used to do more bracing, but I've gone to serial casting is very efficient and does get a lot of good outcomes with that. And then sometimes too, if that kind of the foot deformity stays, a lot of time I'll do some one or two serial casts with bracing. And the braces, again, this is another kind of change that has happened, but some people do brace with these called the foot abduction orthoses. There's a little bar in between, and that is the clubfoot brace. But there's this newer brace, it's the B-Bax brace, that's kind of more for the metatarsus adductus that we've been kind of more going towards. And then again, if this is persistent past age 4, that surgery may be warranted. So when we evaluate somebody for Intoeing, our office, we always get AP legs. And so what we're looking for is we're looking for any pathological reason. This, and again, I'm sorry, it's really hard to see on this screen, but this right here, this is Blount's disease. This is called Tibia Beaking, just evidence of Blount's disease. And then this one right here is rickets, and it's very hard to see, but you can see kind of these cupping right here. There's cupping, but the cupping is not where, like Blount's disease, there's abnormality to the proximal tibia only, but rickets, it's all of them. You can see it up the femur, the distal femur, the proximal tibia, the distal tibia, and then there's that cupping. And these are pictures of, excuse me. This is a normal AP legs here, right here. And then this one where we just got a nice talk about hip dysplasia is that we have caught a couple hip dislocations for a patient that comes in for Intoeing, and we get the AP legs, and the hip, you can see right here, is out. So in summary, again, this is very commonly seen in our practice. You want to just make sure that there's no other reason other than the physiological causes for Intoeing. And then again, the majority of Intoeing resolves on its own. And the most important is parents need reassurance. And one example is our neighbor across the street. Their child is 2. I have a son who's 2. They're the same age, go to the same class. And he Intoes. And my child walks straight. And it's a very controversy. And we play a lot every night, and it's always brought up. And so he was noted at 18 months to Into, Tibia torsion, of course. And again, my child, he's going to walk crooked. Yep, I know. So I brought him in for x-rays, got that taken care of. It's tibia torsion, yes. That resolved, and now he's about 2.5, and now he has femoral anteversion. And I got a text last week, and he's still Intoeing, and he's going to walk funny. What do we do? Well, now it's femoral anteversion. So again, we played with him last night, and he's still in toes. But he's going to Intoe probably until age 8, so we will be having this conversation very frequently. So again, parent reassurance is the biggest thing that we do for Intoeing. Thank you.